Hello. Hi, welcome to my channel. This is Dr. Erica. I'm just going to briefly talk about loading dose, which is the amount of drug that is initially given in hospital setting to a particular patient to get their medication into their plasma, into the bloodstream, so that it can begin to take effect. Now, some patients will receive a loading dose and they'll receive it over a small period of time, over minutes, to make sure that the medication is not actually um, uh, too much for the system or overloading the particular blood plasma, which can cause toxicity and so forth. So we don't want to actually cause toxicity. We want to avoid that. So we, as medical providers, will give a loading dose over a short period of time, again, for safety reasons and for efficacy as well. Now, the loading dose um, is is an estimated amount, um, and the rate at which it is given or administered, again, is for safety reasons and efficacy reasons, because plasma has protein in it. I'm talking about the blood plasma. We know that blood consists of the red blood cells, it consists of plasma, and it consists of protein as well. So the protein can bind to the medication. When it binds to the medication, then that's less blood, or that's less medication in the plasma region. Because it's now attached to the protein, there will be a short or a smaller amount of medication in the plasma. Okay, and so if there's a small amount in the plasma cannot carry enough medication to the uh, location of activity to cure or to work with receptors or to bind to antigens or and so forth. Again, I'll explain it again. So the plasma, which contains red blood cells, protein, and plasma, these all work together to contain the blood itself. Now, when drug is introduced through a loading dose over a small few minute distribution, then that medication is likely to attach to the plasma protein, causing less medication in the plasma. When there's less medication in the plasma, then there's less medication to get to the site of activity where it needs to be. Okay, so when that occurs, there's there's more medication that can be given, or we wait until the medication detaches from the protein to get where it needs to be. Now, also, the distribution can be muscle tissue, it can be organ tissue, and so forth. So if the loading dose begins to attach to the muscles, to the muscle tissue, to organ system tissue, then that can also cause a decrease in the plasma concentration. Okay, and then once that detachment occurs, then the drug can travel back where it needs to be into the plasma and to the site of activity. Now, if there's water retention in the body, such as burns, like third-degree burns, or there's edema, or there's extra fat content, or if there's edema on the lower extremities of the body, then drugs will travel through after the becoming a loading dose, they'll travel through the plasma and then travel on to those third, we call them residual locations, such as the edema, the fat tissue. They'll begin to accumulate in those areas, and then we'll see more more medication in the system, but less in the plasma. Um, the volume of distribution is very important. It plays an important role in the efficacy and safety. I'll read this this small paragraph to you. The apparent volume of distribution reflects a balance between binding to tissues, which decreases the plasma concentration and makes the apparent volume larger. Again, that's because there's more drug that's being accumulated out of the plasma into other areas of the body and binding to plasma protein, which increases plasma concentration and makes the apparent volume smaller. Again, that is because the drug is now traveling again outside of the original plasma concentration into the tissue area. Changes in either tissue or plasma binding can change the apparent volume of distribution determined from plasma concentration measurements. An apparent volume of distribution reflects a balance between binding to tissues, which decreases plasma concentration and makes the apparent volume larger. So that says when the medication binds to organ tissues or to those extra locations, or such as edema and fat content in organ tissues, then the volume in the plasma seems to be larger when actually it's not. The concentration is the same. It's just that the medication has now traveled to other areas and have become bound to those areas. Okay. Now, the volume of distribution may be overestimated in obese patients if based on body weight, and the drug does not enter fatty tissues well, as in the case, for example, with digoxin. Digoxin is a heart medication, and I mentioned it before that this medication is very specific, and it has a lot of drug interactions, a lot of drug organ interactions as well. So do be aware of that if you're taking digoxin. Okay. In contrast, theophylline is another drug, and it has a volume of distribution smaller than that of the total water body water. Adipose tissue or fat tissue has almost as much water in it as other tissues, so that the apparent total volume of distribution of the theophylline is proportional to body weight, even in obese patients. Abnormal accumulation of fluid, edema, pleural effusion can markedly increase the volume of distribution of drugs such as gentamicin and hydrophilic medications, most medications that love water. Um, and have small volumes of distribution. Okay, so that is what I was trying to explain earlier on in the video, that accumulation of fluid, burns, skin burns, burns internally. Those areas can cause an accumulation of medications, causing a change in the distribution of the medication, especially with drugs such as the hydrophilic medications and the antibiotic gentamicin, for example. So that's what I want to go over in this particular video for medical students, for pharmacy students alike who wanted a brief overview of loading dose and volume of distribution. I'm reading from the reference text, Basic and Clinical Pharmacology 11th edition. So do look into that. And there are some calculations for loading dose, which includes the amount in the body immediately following the loading dose, a volume of distribution, and then and then it has the volume of distribution, which is going to be equal to loading dose. When you multiply the volume of distribution times the, let's see, this is the total target concentration. So target concentration times the volume of distribution is going to equal your loading dose. And then the actual amount, the rate of administration can be crucial in preventing excessive drug concentrations and slow administration of an IV drug. Okay. It's almost always prudent practice for IV doses such as theophylline initial injections should be given over a 20-minute period to reduce the possibility of high plasma concentrations during the distribution phase. Okay, again, so you want to, particularly with theophylline, for example, give the medication over 20 minutes as a administration rate to help reduce the possibility of high plasma concentrations during the distribution phase, because theophylline is going to combine with organ tissues, with fat tissue, and so makes it looks more expanded in the body. So we want to make sure that we're not loading too fast or to cause toxicity to the body. So we want to give it at least a 20 minutes period. I can go over intermittent doses. The loading dose calculated from equations will only reach the average steady state concentration and will not match the peak steady state concentration. To match the peak steady state concentration, the loading dose can be calculated from the equation accumulation factor times the maintenance dose, which is going to give you the loading dose. Okay, so the maintenance dose is the dose after the loading dose. The maintenance dose is going to be the doses that are going to be given IV after the loading dose times the accumulation factor is going to help determine your loading dose. So the intermittent dosing are given, when intermittent doses are given, the loading dose calculated will only reach the average steady state concentration. It will not match the peak steady state concentration. So the peak steady state concentration is going to be calculated from the maintenance dose times the accumulation factor. And then the initial loading dose, which is the average peak concentration, is going to be multiplied by the volume of distribution times the target concentration. I'll put that in the description box for you to go over. And again, that is from the reference textbook, Basic and Clinical Pharmacology, 11th edition. This is a good review of loading dose, volume, and distribution, and maintenance dose as well. So thank you for joining me on this particular video. Have a great day. Bye-bye.